Welcome everyone to SME Symposiums. Today we are going to be talking about medical interviews, how to master them, and how to ace your medical interview when you do get around to doing it. Now, some of you here might have already even done some medical interviews or seen what they're like, but we do have someone, Dr. Simren Dhaliwal, who's going to be coming in and speaking about it more specifically in regards to the sort of intricacies and different aspects of it that you could expect, and just general tips and tricks to help you improve. Now, I know we're probably still waiting for other people to join, but just for the sake of punctuality, we'll get on with it. So first of all, I just want to say, for those of you who are joining us for the first time, welcome to SME Symposiums. What we do over here is we have monthly webinars, and essentially they are just dedicated to keeping you updated on relevant and important medical topics like interviews. What's more important than that? Everyone is welcome. It's completely free for all to attend, SME or non-SME students. As you guys know, we usually talk about the topic and we have a little bit of a Q&A at the end. And you will get a feedback form link at the end. Once you fill that out, you will get a couple of things. So you'll get a certificate for attendance, and you will also get a 50% discount code for Lectorio. And with Lectorio being mentioned, sorry, that was the next slide. So our speaker today is Dr. Simren Dhaliwal, who's a FY2 in Kingsmill Hospital. Dr. Dhaliwal has been on with us before. I've worked with her on multiple projects. She's a great presenter, and she knows how to give some real insight to students. She herself is an IMG, so feel free to bombard her with questions in the Q&A box at the bottom of the screen. What I will do at the end is I will just select the most relevant ones if there are too many, and I'll just hit her out with those questions. So this is the program for today. I'm just getting through my small little intro, and then I'll hand it over to Dr. Dhaliwal, and then basically we'll have a small Q&A at the end. And just before I do hand it over, I'm going to quickly talk about the scholarship prize draw. Now, SME is offering a total of 45 scholarships to 2022 applicants. Now, I know some of you who are joining are probably fit in that criteria. So what we do every month at the end of the symposium is we have a draw and pick 5 lucky winners who get half of their entire tuition fee paid for, which is absolutely ridiculous. That's a lot of money you guys are saving. So if you are a 2022 applicant, you can still enter. Go to studymedicineeurope.com, and you should see this article over there. And if you click on this little yellow hyperlink SME scholarship program, you should be able to fill it in and enter the draw. And of course, a big thank you to our partners and sponsors, Lectorio. So as you guys know, it's an all-in-one study resource for medical students that combines learning science and medical education into one easy-to-use platform. You've heard me say that 100 times, and I'll say it 100 times again, because it's true. I love them. They're great. They're absolutely wonderful. I think we even have a couple of 6 months free passes. So if you fill in the feedback form at the end, we'll pick a lucky winner and email you the 6-month pass as well. And of course, everybody gets the 50% discount code. Okay, so without further ado, I'm going to bring on Dr. Dhaliwal, who's going to be looking after you from here on, and she will be speaking about mastering medical interviews. Thank you.
Hi, okay, so I'm just about to share my screen, and then you guys can see the PowerPoint. So can everyone see this and hear me? Hoping.
Yep.
Yeah, okay, I'm just going to keep my camera off for now because sometimes I feel like that distracts you guys from the PowerPoint, if that's all right. Okay, so I'm going to be talking about mastering the tips for an interview. So interviews can be really scary things, and I've been through a couple of them, and the build-up of them is not as scary as the actual interview seems. So I'm going to talk about what we're going to go through today. So I'm going to talk about how you can prepare for an interview, the best things to do, the tips and tricks that I used, the actual format of an interview. So there are a couple of hurdles you have to go through. It's not just a clinical question. There's a mixture of a bit about yourself. Sometimes you can be presented with a question that you don't necessarily know the answer to, so I'm going to tell you how to handle that. Little things that I think if someone had told me when I first did my very first interview, I think it probably would have been a lot more smoother. And just some tips you can use, and these will apply no matter what rank you go on throughout your career. So on Thursday, I was helping the interview process for registrars in surgery. And literally the structure and the base is exactly the same how it is for FY1s and FY2s. It's always the same. It's always going to be a clinical question about yourself, and something about situational judgment. So preparing for the interview. So most interviews nowadays all happen on Zoom because of Corona, and also just because it's more convenient. It's a lot cheaper as well for both parties. So you want to always make sure you've got a clear background. You want to have no noise or what's around you. You want to make sure that your background is clear. So preferably a white or a cream background is always the best thing. And you want to make sure you arrive on time. You want to be early. So you should be the one waiting in the waiting room. The worst thing is having them, wait for you or have an internet connection issue or something. It just shows that you're unprepared, you have bad timekeeping skills, and that's not the best qualities that you're showing of yourself, because the interview is your time to shine. And you want to always make sure you know who's interviewing you. So it's always going to be a panel of 3 or 2. One will be a doctor, one will be someone from HR, and sometimes there'll be another doctor. So you want to know, what does this doctor do? What does this doctor specialize in? What grade is this doctor? And you want to also have a little bit of information on the person who the HR person is, because that's who you'll be liaising with regarding your whole process, in terms of paperwork or anything else. Sorry, let me just turn my camera on. Okay, so the next thing we're going to talk about is, why is my screen not moving? So the structure. So the first question is going to be, tell me about yourself. So they're going to want to know, something really basic like, where did you grow up? Where did you go to uni? And as an international graduate, the first question we always had that is, where did you go to uni? And they want to know, why did you go abroad? And that's completely fine. They're going to want to know why you went abroad. And the way you need to word it is you need to sort of flip the situation. So it's a known fact that the majority of us go abroad because of several different reasons. It's too competitive in England, grades, UCAT scores or whatever. But you don't want to tell them that. You can bring up a variety of different answers. Things like you wanted to explore, you wanted to go abroad, you wanted a different experience, studying abroad is cheaper. Well, at the time it was anyways. You can bring that into account. When they ask you a question like, tell me about yourself, that's a very broad question. And that can be a very scary question, because what are you going to say? So you want to structure it to be a bit like, what are your best qualities? So I'm great timekeeping skills, I'm very punctual, I like to be organized, things like that. Something funny about yourself, like, oh, I'm the head of whatever sports or football team or something. You can talk about your ethnicity and bring that into an account. You want to show yourself to be different. You need to make yourself stand out. Now, they're going to pick apart your CV and ask you some questions. So they might be like, tell me about yourself, Samantha. And Samantha might be like, oh, I'm a foreign graduate. I studied in Bulgaria. I really enjoyed myself out there. I learned many different qualities. I'm also the captain of the football team, and I also participate in charity work. That's a quick snapshot. She's given where she studied, why she went there, what she does outside of medicine, and what she likes to do in terms of humanitarian care. That's just a quick snapshot. She's grabbed that person's attention. Now they want to ask her more. Now, everything that Samantha has spoken about in that situation has some relevance to information placed inside her CV, which is perfect, because now what they're going to do is they're going to ask her questions about what's written in her CV. So not only has Samantha showed she knows what's in her CV, it also looks like it's not a lie. One thing that interviewers hate is people who lie inside their CV. So you don't want to write something in your CV like, oh, I don't know, I raised £10,000 for some random island or something. That's obviously a lie. and they're going to know it's a lie, and that's just going to make you look like an idiot. You don't want to do that. So they might pick something random from your CV. So you might have written that, I don't know, in 2019, you had a clinical attachment at a hospital somewhere in vascular surgery. They're going to ask you about, what did you learn from that experience? You need to have something about it. You can talk about how you learned about the process of a ward round. You could be really specific and talk about something particular in vascular surgery, like, oh, you know, I learned the management for a AAA, or I learned the different gradings, or like, I learned how the NHS manages. You need to keep the NHS in the main domain in your answers when you're talking about your clinical attachments. So remember your CV, talk about yourself, make it quick, short, and make whatever you're saying about yourself relevant to what's in your CV. So clinical question, this is their favourite bit, because this is when they want to test, do you have the same knowledge as a British graduate? So always remember your AtoE, so airways, breathing, circulation, disability, and exposure. So airways is it patent? So how are you going to tell if an airway is patent? The patient can confirm their name and date of birth. Breathing, so you're going to auscultate with your stethoscope, you're going to listen for any crackles, crepitations, check the oxygen saturation rate, which will be obviously given to you by the nursing staff. You want to know their respiratory rate, so the average rate is, you know, between 12 and 20. You want to see, you know, what's the range of that. And in some cases, you may want to perform an ABG, which is an arterial blood gas. C, you want to know your circulation, so are their peripheries well perfused? Are they warm? Are they flushed? BP, heart rate. Then you want to look at disability. So you want to look at their abdo exam. So is their abdomen soft, non-tender? What is their glucose level? And then exposure, you want to expose the patient and look at their skin and anything else that could be causing it. So that's your basis of an AtoE. Now, no matter what the situation is, whatever question they throw at you, if you can show you know your basics of an AtoE, you're halfway there. So they could ask you something ridiculous that you've never come across. You know, you're starting off in your career, you're not going to know everything medical, and that's completely fine. It's okay not to know something, but showing them that you know the structure of an AtoE process is perfect. So let's start with a question. So one classical question they'll give you is, you're a junior doctor on an acute ward and you're clerking a patient who has come to you with shortness of breath, with a history of COPD, and the nurses have informed you that the SATs have dropped from 92% to 82%. What are you going to do? This is a classic question. So what they want to know is how are you going to handle the situation? So we've spoken about our AtoE. So we're going to go through airway. So you'd say, you know, I would go in and I would assess the patient. I'd confirm the patient's date of birth and their name. They'd obviously then tell you at this point, patient can confirm, and you'd be like, brilliant. So you know the airway is patent. I'd then go on to auscultate the patient's chest to see. They might tell you that there's crepitations present. So then in that case, you might be like, okay, you want to know their respiratory rate, their oxygen saturation rates. You saying all these key points and hitting all these key parts is showing them that you know your AtoE assessment. You know what the right questions are to ask. You know what to do in a situation that you're thrown into, even if you don't know what you're doing. You're showing that you're organized, you're methodical, you've well thought out, use your resources. You can talk about how you'd ask the nurse to check the oxygen saturation, you'd ask the nurse for the observations on arrival. And then you go through C, so you check, say, I check to see the capillary refill, so is it less than 2 seconds or is it more? Check the blood pressure, check the heart rate, then you go on to the abdominal exam, and so forth. So you'd show your AtoE assessment. So in this case, we always need to remember is that COPD patients keep their oxygen saturation rates between, they keep their oxygen saturation rates between 88 to 92. So that's the first thing you need to remember. So there being a drop of 92 to 82, you should be concerned. And you want to always remember your AtoE assessment. So we go through, is airway patent, breathing, circulation, and then you go through the disabilities and the exposure. What they want to know is, it's okay, they're not going to ask you, you know, what do you think's happened? They might ask you that right at the end, and you're going to say, oh, it looks like it could be an exacerbation of COPD because the patient's presented with having, you know, an increased shortness of breath. But if you don't know the actual diagnosis, that's fine. You just need to show you know your AtoE assessment. You also need to show you know when to escalate. That's what they want to know. So in this situation, you talk about the AtoE, and then and then at the end they might say, what do you think's wrong with the patient? And it's completely fine if you say, oh, I don't know, maybe it could be that there's an infection and somebody's got COPD. That's fine. You could say they have exacerbation of COPD, which is what the patient actually has in this situation. They don't expect you to know treatment plans. So they're not going to ask you, what antibiotics are you going to administrate? Because in reality, you're not going to know the answer. So you don't need to know, oh, it's amoxicillin, TDS for so many days. That's fine. You don't need to know that. But you showing that you know the basic skills of how to manage it is the answer that they're looking for. So another one is, so again, like I said, so this is actually how you would do it. You do the AtoE assessment, go through the airway. If they're, obviously we know that the oxygen saturation rate has dropped from 92 to 82. So we're going to give them high flow and oxygen. This is one of their favorite questions. They will ask you, what is the rate of the high flow oxygen? You're going to say 15 litres of oxygen. That's your go-to answer. That is what they want to hear, and that is their answer that they are looking for. They will use that question to trip you up because they know that in Bulgaria, we don't use this. We don't, have this whole AtoE assessment. We're not exposed to it that much. We don't know about this whole 15 litres of high flow in oxygen in a non-rebreather mask. That's what your answer needs to be. ABG is just for extra brownie points, and obviously you guys are going to know about this, so you're going to shine out more. But you would say, because the oxygen saturation rate is so low and is below the normal limits, I'd perform an ABG on the patient. You can get a fellow colleague to perform an ABG in that situation. So you could say, I would ask a colleague or myself would perform an ABG. I'd ask the nurse to administrate salbutamol nebs. Always review the drug chart because you want to know what medication the patient is already on and what medication the patient is taking. Can ask the nurse for help. They've told you that you're a junior doctor in an acute ward. Nurses will always be available. And then you can always go through what you think the diagnosis is. So the next one is, you're a junior doctor on a surgical ward and you have been asked to review an 87-year-old lady who is 3 days post-op from a hip replacement. What are you going to do? This is by far, I think last year, the most talked about scenario. This was exactly the scenario that they used in so many people. One of my friends had them. I had this scenario as well myself. And that's because in England currently the hot topic is PE, which is pulmonary embolism. Loads of hospital patients are having pulmonary embolisms. And this is because they're in hospital, they're lying in bed, they're not moving around. And so they're developing blood clots, which are then traveling to their lungs. And as a result, it's either causing death in severe cases, we're having to thrombolize them, they end up being on anticoagulants for the rest of their lives, and it's just, they come to us with one problem and we create another, essentially is what's going on. And so they want to know you know how to handle this, because in England, all the medical students are taught about how to handle the PE and what the signs are to look for, and this is a hot topic for them. So if you know how to handle this, this is probably the most difficult bit that they will ask you about, is a pulmonary embolism. So you're going to start with your AtoE. So you're going to do your AtoE structure. So you're going to say, check for airways, check for breathing, circulation, disability, exposure. You're going to ask to look at the news score. So whenever you're put into this situation, you should say straight away, I want to know what the news score is. And we're going to talk about that afterwards. You want to review the drug chart, always review the drug chart to see what medication the patient is already on. So in this situation, we know the patient is post-op. Post-op means that they've just come out of surgery. They are at more risk of developing a pulmonary embolism. So you need to look, are they already on anticoagulants or not? They should be on anticoagulants. So checking the drug chart, you would say, I'm checking the drug chart because I want to see if the patient's on any anticoagulants. If they're not, then they've probably got a PE. You want to check their bloods to see, is there any blood loss? Has there been any hemoglobin dropping? And you want to ask the nurse. You'd always say, I'd ask the nurse to do this. I'd ask the nurse to retract obs. And when you feel like you're out of your depth, you need to escalate. So in England, a big thing that they're hot about is junior doctors knowing when to escalate, because there's been so many situations where junior doctors have not gone on to ask for help. And what's that resulted in, patients ended up in severe situations like ITU, death, an extra problem occurring that shouldn't have happened. So consultants especially are really hot on their juniors knowing when to escalate, because your consultant will be there in the morning, he'll do the ward round. He'll then disappear to clinic or, you know, referrals. He's trusting you to look after his patients. It's his name on there. Anything goes wrong, yes, you're liable for something, but ultimately your consultant will be liable for not checking in on you. So he needs to know, every consultant needs to know that you know at what point you're out of your depth and you know when to call for help. So in this situation, you're very new to this. You know, you've been asked to review a patient who's 3 days post-op and she's got, I don't know, really increased respiratory rate. So you're going to check her airway, is it patent? You're going to check her oxygen saturation rate. Oh, it's a little bit low. I'm going to administrate 15 litres of high flow oxygen. I'm going to then check for circulation. Blood pressure is a little bit low. So if anybody's blood pressure is below 90 systolic, administer a stat bolus fluid. And what that is that's 500 ml of normal saline. That's what the guideline says, 500. It's okay for you to say 250 because a patient may have heart failure. You want to administrate fluid, you want to give it to them, stat quickly because we want to increase their blood pressure, and then you want to go on to perform the rest of your examination. You just basically need to show in all these clinical questions, I know I keep repeating myself, that you know your AtoE, because it's okay if you don't know about, like, you might not know about PE. Like, I didn't know that PE was such a hot topic when I first sat my interview. But because I knew my AtoE, I was able to be a bit like, oh, this is what I would do. This is how I'd handle it. When I personally felt like I was out of my depth in that situation, I said I need to escalate. And I actually escalated really quickly in that situation. I did my AtoE and I think I got back to C when they were like, oh, I asked them what the blood pressure was and they were like, oh, it's 88 over something. And I was like, I'd administrate stat fluid bolus and then I'd escalate to my senior. And they, at the end, the feedback they said was, oh, you know, that's absolutely fine. You might have escalated a little bit too quickly, but the main thing is that you escalated. So they want to know that you know when you're out of your depth and when to escalate. Obviously, when you start doing the job and you do it for so many, you know, months or so ever, you become more confident and then you realize, you know what, the blood pressure is not that high. I don't need to escalate, or it's not too low. I don't need to escalate that quickly. But when you're just starting off, they want to know, you know, when you're out of your depth and you know what is and what isn't within your depth. So always know when to escalate. Or you could perform the whole AtoE and then escalate afterwards, and that's completely fine. You can say, you know, I'll, you know, go through your AtoE, airway, breathing, circulation, disability exposure, and then at the end I'd inform my senior to alert them to know what's going on and document it nice and clearly in the patient's notes. That's completely fine. That's a very good answer as well. In this particular scenario, when they're giving you this really like vague situation of, oh, you know, you're a junior doctor on a surgical ward, post-op 3 days, they will ask you, what do you think the diagnosis is? And there's loads of things you could say. You could say, oh, you know, the patient's elderly, she could have asthma. But the main thing that they want to know is PE. That's the main answer, is PE. Because anyone who's had a surgery, PE is one of the highest causes of, you know, shortness of breath or whatever. So obviously they'd give you more context, they'd give you the past medical history, and you can ask for that as well in this situation. But they'll start off with a vague question to see, do you know the right questions to ask? And do you know what you're looking for? And that's the main thing. So another scenario would be, you're a junior doctor on a medical ward at a night shift, and you've been asked to review a patient who's experienced chest pain, and the nurse has informed you that, you know, it's been mentioned that it's radiating to the left side. What would you do? This is classic MI situation. That's what should be coming through your head. Chest pain, radiating to the left side, you should be already thinking about, you know, maybe it could be a heart attack. But you obviously not going to jump in and be like, oh, this is a heart attack, that's the answer. No, you need to show the whole AtoE assessment. So airway, is it patent? I'd ask the patient his name, confirm his date of birth. You're doing that for 2 reasons. A, to show that the patient's airway is patent, but also to show that you are checking that this is the right patient and is the right date of birth. There have been so many situations where patients have been moved, you know, during the night. They swap beds because the nurses are moving them around for whatever bed managing duty that goes on. And you might have been a junior doctor on that ward a couple of weeks ago, and it's the same patient and he was still in the same bed. And you're like, oh, you know, this is John Smith, 87, blah, blah, blah. It's actually not John, it's probably someone called Adam, but they've swapped the beds around, but you don't know that. So always confirm the name and date of birth. Breathing, auscultation, so you're going to pop your stethoscope in, you're going to auscultate the chest, front and back, listen for any crepitations, any wheezes, because chest pain can also happen as a result of pneumonia. Pneumonia-related chest pain is actually a thing, so you want to check, is there any chest pain involved? Then you want to go on to ask heart sounds, blood pressure, heart rate, are they well perfused or not? Then you're going to do your abdo exam. Is the abdomen soft, non-tender? Sometimes they can have referred pain. They could actually have something going on in their abdomen. They might have a distended abdomen and they might have pain in their chest because it's referred. So you want to do all of that. Then you're going to expose the patient. So you're going to remove the blanket covering the patient. You're going to check their legs to see if there's any rashes anywhere. Are their calves soft, non-tender? Why do you want to check if their calves are soft, non-tender? Because if they're not soft, non-tender, they could have a DVT. And then a DVT obviously means it will later on lead into a PE. And then you want to, and as you're going along, you want to say, oh, this has happened or this has happened. So they might say, you've checked the airway and it's not patent. What are you going to do? And you're going to just say then, I'm going to perform a head tilt chin lift, and then I'll administrate high flowing oxygen. You want to check to see if there's anything in the airway. You're allowed to say, oh, you know, I'd call anesthetics to come and review to place an airway in. You just need to show you know how to perform an AtoE, you know how to administrate, you know how to escalate, and you know how to use all your resources. And if you do that, no matter how difficult the clinical situation is, you'll be absolutely fine. Like let's say you didn't know that this person was having a heart attack. You didn't realize that this was a classic presentation because you were so nervous. It's completely fine to say at the end, oh, you know what, I'm sorry, but I'm really not sure what is going on here. That's fine. It might make it look a bit bad in terms of your medical knowledge and judgment, but you've performed the AtoE, you've showed them that you had the right thought process. Could be down to nerves that you're having a bit of a memory lag or whatever, but you just need to show that you know some form of medical knowledge. It's not an exam. It's not like our exams in Bulgaria where they're going to be like, oh, you've got a 6, you've aced it. No, they just want to know you know something, or you know the structure. And then when you start working, you'll realize that there are loads of doctors that actually don't know what they're talking about, or there are some doctors and you're just like, they check their guidelines for everything, and that's completely fine, because in England they make guidelines for absolutely. There's a guideline on how to treat a heart attack, for example, which is literally so basic that every Tom, Dick and Harry can read it, but just because you're a doctor, you're the one that's able to treat it, but you have that guideline there to use. So you can even incorporate into your answer, I'd check the trust guidelines to see what is the correct medication needed, and I'd inform the med reg. So on your nights, your med reg is your point of escalation when you're working in medicine. You don't have a consultant overnight. So anything bad happens, med reg. So now you're showing to them that you know who to escalate at different periods of time. Does that make sense? So you've done your AtoE, you've reviewed the drug chart, you've done the bloods, you've done an ECG because they're having chest pain. You're going to check the trust guidelines to administrate a treatment plan for the patient. And then lastly, you're going to escalate and you're going to inform your med reg to be like, there's a patient on ward 32, B-Bay, bed 4, experiencing chest pain. You tell him your AtoE assessment, you've reviewed his drug chart, you've checked his bloods, the ECG, the findings, so is there, ST elevation or not. I'm going to ask for a troponin level, so I'm going to request bloods to be done to see if their trop has been increased or not. My treatment plan is, once, let's say there's no ST elevation, I'm going to wait for the trop levels. Once the trop levels are back, I'll then give some anticoagulation, so my fondaparinux, my aspirin, my clopidogrel, and then you've informed the med reg, you've updated him, so he is aware that there is a patient on a ward somewhere in the hospital who has experienced a heart attack. And that's the main thing, is that you've shown to them that you have clear organizational skills, you've got a clear thought process, you know what to do, you know how to remain calm within a situation, and you know who to tell and what to do. Okay, so then they have the situational judgment question. So this is something that a lot of us are not prepared for, because when we study in Bulgaria or in other countries, we don't really have this, like, You have medical ethics, and that's more of a, you know, the situations when patients have an ethical issue and how would you act. These are questions more like your registrar turns up drunk, what are you going to do? Or, you know, your consultant's been dismissive towards you, how are you going to approach it? It's things like that. They want to know you know how to react in non-medical situations, because being a doctor is not about treating someone, it's about being an all-rounder. So you want to show that, you know, this is how I'd handle the situation. You want to show you're not a confrontational person, you're not someone who's argumentative, you're not someone who's going to, you know, punch the registrar in the middle of the hallway because, you know, he's ignoring you on the ward round or something. They want to know that you're a calm, well-mannered human being who knows how to handle certain situations that are not just medically related. Classic one they love to use for F1s and F2s is, you know, you've noticed your colleague has prescribed a medication wrong. How are you going to handle this situation, or how are you going to approach it? Really simple, you know, I'd go up to my colleague, I'd just ask him, did you mean to prescribe this medication? Or, you know, was there a reason you needed to do this? You'd ask them, and if they say, oh no, I'm really sorry, you know, I've documented it wrong, just like, that's fine then. Ask them to cross it out and ask them to rewrite it. If it's a reoccurring problem and you've noticed it, then you're allowed to inform the, you know, your registrar, for example, who's your escalation point at this point, to be like, oh, you know, Samantha keeps prescribing the wrong paracetamol dose for a lady. I don't know if she is doing it intentionally or not, because you've showed that you've escalated it to the person. It's still happening. It's still an ongoing thing. So then you've gone and escalated to a senior. And the whole thing is the patient safety was the center of your issue and the center of your concern, and you acted upon it as necessary and as needed. The one about your reg coming to work late constantly, and like, so ward round's supposed to start at 8, your registrar's always turning up at 8:30. He'll say sorry, but you know, he doesn't seem to be too bothered because he's running late, ward rounds are running late, and as a result that means that you're staying behind after work to finish off all the jobs because you don't have enough time in the day. How would you approach the situation? So it's really simple. So I had this situation in my first interview, and this is exactly how I said it. I was like, I take my registrar to the side, I just have a little chat, like, is everything okay? Is there a reason why he's always late? Now, how you approach that situation, you're his junior, right? So you're not going to be a bit like, oh, why'd you turn up late for work? You're going to be a bit like, you know, I don't know, let's say his name is Jack. You know, hi Jack, is there anything that's wrong? I've noticed that you turned up late a few times. Are there any issues? You know, is there anything that I can do? So you're showing that you want to be as helpful as possible. It means that you're not showing that you're being confrontational, you're trying to be approachable and friendly. He might be like, oh, you know, I'm really sorry, I had some childcare issues, and you can be like, oh, that's fine. You know, is there anything we can do in terms of us juniors? If it's a repetitive thing, then obviously you'd say, I would confront my registrar. I would also then alert my educational and clinical supervisor. So who are these people? Your educational supervisor is someone who is a consultant who will look after you essentially over your period of a year, and he will meet up with you every 3 months to see how each rotation is going. Your clinical supervisor is a consultant who will be in charge of you for the 3 months duration of each rotation if you're doing a rotational job. And these are people you can escalate to when things go wrong. You know, if you're staying late at work for too long, like every Thursday, because of this one person, you're staying behind after work for an hour each Thursday. You can tell your educational clinical supervisor, like, this is a standing issue, and they can figure out how to help you. They make sure that you get paid extra for those hours. They'll make sure that if there's more staffing needed on the ward, and look into why is it that every Thursday you're staying behind after work. So these are your people that are actually on your side. Think of it like that. So they're people that want to help you, and they're people that you can go to. If you're having any troubles at work, registrar's being rude, another consultant's being dismissive towards you, or you feel uncomfortable, they're your people to go and talk to about it. So again, incorporating that into your answer is showing that you know how the system works. You just need to show you know how the system works in every way you answer a question, because they don't want to have to employ somebody who doesn't know how the NHS works, who doesn't know how the system is. You know, for them it's time consuming. They can't be bothered to always, you know, give you time and effort to explain how things are. They want to know, you know what you're doing, you're fitting really well, you know how the system runs, and you're going to make it a smoother process. You need to sell yourself as being, I'm amazing, I can fit in, I know what this is and I know what that is. And it's completely fine if you don't when you get there, because then you're going to learn afterwards and then you're going to find out. But you need to show and have some form of knowledge and some form of ability that shows them that you can adapt and fit into them. The biggest thing is that they want to know you will fit into the NHS, and the NHS prides itself on situational judgment questions. I mean, registrars get asked this question to this day, and so do consultants when they have interviews. So it's exactly the same for all of us. So throughout your career, you'll be given a clinical, a situational judgment question, and of course, a question about yourself in the hospital. So lastly, they're going to ask you about why you choose to apply for this hospital. Sorry about that typo. This is a really big question that I was shocked about, and I did not expect it. They love to ask you, why have you chosen to work here, or what made you want to apply? And you need to find something very unique to this situation. So you don't want to be like, oh, I've heard it's got a really great training program. Because the next question they're going to ask you is, what training program are you interested in? And you haven't done any reading and you're just going to fall. So one of the things that I would always advise is Google the hospital. So when I applied for one of my jobs and it happened to be in the middle of nowhere, I was like, oh my God, what am I going to say? And it turned out it had it was one hospital in 10 in the country that had a hyperbaric chamber. I don't know what that is. When I applied, I didn't know what that was. And I did loads of reading on it. And then when I went to apply for the job, that was my talking point in the interview. I was like, oh, I'm really interested in this device. This is why I chose to apply, because I was really interested. Reality is I never saw that hyperbaric chamber during my entire time being at that job. But it just shows that you've actually had interest in this hospital, that, you've taken your time into knowing why you want to go to this hospital. For example, if you go somewhere in London, they might be like, oh, why did you choose this London hospital over another? You used to be like, read about it. It could be something historical, for example, like, I don't know, this was the first hospital to perform this procedure and it's always been a dream of mine. Just show that you have an interest and that you know something about the hospital. Nobody wants to employ somebody who doesn't know where they're working. And that's essentially what it will look like. You don't know where you're working. They'll ask you what your future is and what your aims are. It's completely fine to say you don't know where you're going in life. Like when they asked me, where do you see yourself in 10 years time? I was really honest and I was like, I don't know where I'm going in 10 years time, but I know that my goal is that I want to achieve this, this, and this. But I ultimately don't know what I want to specialize in, or I don't know if I want to stay here for the rest of my life. And, I don't know if I want to remain in this hospital, and that's completely fine. Alternatively, you could be like, oh, I know I want to specialize in cardiology. These are my dreams. This is my goals, blah, blah, blah. And, show them that you've got that. They want to know you've got some form of direction, some form of drive, because you will be an asset to them. They don't want to employ somebody who, just wants to come to work, just wants to go home, has no real interest, doesn't really want to progress further in their career, because you're not an asset to them. You need to sell yourself. So, you could be like, oh, I really have an interest in teaching, so that's something I was looking forward to doing, or research is something that I'm really interested in, or I really want to learn as many procedures as possible. And that's completely fine. That's a really good talking point. And when they ask you if you have any questions, please don't talk about money, because first of all, you're too young in your career to be doing that, but also HR are who deals with this. So in your interview, when you're actually in there, you'll be interviewed by a doctor. And you don't want to be like, oh, I want to earn this much. They're going to be, I have no clue what you're talking about, because they don't sort out your pay package. That's HR. So there'll be someone from HR sitting in your interview who will be scribbling everything you say, but they won't actually have much to talk about in terms of talking to you in the interview. They'll do all that with you afterwards. You'll exchange emails, you'll exchange phone calls, all the paperwork process, all that will happen afterwards. Now, there are a few questions I don't know if you guys will have, but these were a few that I had when I was starting, and it was things like start dates. You're allowed to say like, oh, this is my preferred start date, or, oh, I have some commitments or something, so I need to start at this point, and then that's okay. And they have to allow you that time, because you're starting their job at whatever given point, and they will hold your job for you if they like you. Because, for example, the job that I'm currently in, I needed to start it actually a month later than what they asked me to start because of the job that I was previously in. And they were completely understanding about it, and they understood that, and they were like, that's fine, and they accommodate. And so don't feel shy to be like, oh, I have a question, or, you know, this is what I need to do. My biggest thing is don't lie. They will catch you out. It'll make you look like a fool. It makes you look unreliable, unfaithful. And in medicine, everybody talks. So NHS is actually a very, very small place, and people talk a lot. So you might be like, oh, I've applied for a job here. You know, you've worked there for a couple of months and then you move somewhere else. You'll be surprised. In that hospital, somebody will know somebody from where you've worked. And you want to leave a good impression no matter where you go. And when you leave, you want to leave a good impression too. So just don't give yourself a reason for a bad reputation to follow you. Even if in the interview something goes wrong, you know, it's fine, stay calm, don't worry about it. You know, mistakes happen. They understand that. They know that, you know, this is a very daunting process, and they do try and make you feel at ease as much as possible. But just try to make sure that you take your time, you know what you're talking about, and you don't seem very unorganized and very like frantic with your thoughts. So difficult questions. So ask them to repeat it. You know, for example, you could be in that clinical situation that they've given you a question and you don't know how to handle it. And that's completely fine for you to be like, oh, can I just have a minute? Or I'm really sorry, can I just think about it? Or can you repeat the question again? While they're repeating the question, you think it through. Take your time and answer it to the best of your ability. So let's say they ask a question like, for example, situation judgment, and you don't know how to do it. They might be like, your registrar's turned up drunk, how would you handle it? And you can say, I'd escalate it to my consultant, but I wouldn't feel comfortable confronting my registrar. I'm not really sure what other avenues there are I should go through. I'm really sorry about that, but this is how I would handle the situation to my best ability. That's completely fine. You've shown that you're honest. You're showing that you're not trying to bullshit. And you've also shown, sorry about that, you've also shown that you have some form of knowledge, you have some form of avenue of what to do, but you're not somebody who will create something out of nothing. So it's okay to answer the question a little bit to the best of your ability, and then put your hands up and say, I'm really sorry, I don't know, like, that's fine, because they actually admire you saying, this is out of my depth, I don't know what I'm doing, because it shows to them that you know your limits. And that's one thing that people in the NHS pride themselves on, is knowing your limits. They don't want to hire somebody who doesn't know his limits, because then you end up being that reckless doctor who doesn't know what he's doing, never knows when to escalate, his patients are always in danger, and the nurse is always scared to work with you. That's not the reputation you want to carry for yourself. So, you know, you want to show that you know what to do in a situation, and if you don't know what to do, you know when to ask for help. Don't try and act like you know something when you don't. They'll see straight through it. You know, they might ask you something like, how many cannulas have you done? It's completely fine to say, I've only done a couple, I haven't really done that many, but I'm eager to learn and I'm really looking forward to gaining some more experience. And that's a perfect answer, that's completely fine. They might ask you things like, have you ever done an ABG? I'd never done an ABG, I'd only ever done one femoral stab when I started to apply for my job. And they asked me that, they were like, you know, is there any practical experience you have? So I would advise read through the 15 core competencies that you're expected to know as an FY1, because obviously we all graduate from Bulgaria or whatever countries, and you graduate from 6th year and onwards, and that's technically your internship is the equivalent to an FY1. And so if you read the FY1 competencies, there are 15, so that's things like blood taking, ABGs, ECGs, spirometry, and things like that. You can say, okay, well, I have some practical experience with the 15 core competencies. These are a few things that I'm lacking, and, you know, whatever. And you can say that to them, and they can say, okay, that's completely fine. Like, you know, what areas would you like help in? And this is when you tell them, oh, I'd like to gain more practical experience. I'd like to become more confident in doing this. Or, you know, I have a particular interest in learning how to do ultrasound. And you can say that to them in the interview. They will ask you things like that. But whenever you're answering a difficult question, ask them to repeat it, take your time, answer it to the best of your ability, and it's okay to say you don't know, because we don't know everything and they don't expect you to know everything, so it's fine. So my top interview tips: read your CV. So make sure your CV is short and sweet. You want to be able to have an interview, right? So in order to get an interview, you need to make sure that your CV isn't pages long. They don't want to read your monologue or your autobiography. They don't want to read that. They just want to know your name, your address, how to contact you, are you vaccinated or not? This is a really big thing recently that they want to know about. Where did you graduate? Do you have a driving license or not? What your experiences are. So any courses that you've been on to, so, things like ALS, surgical skills, any conferences that you've attended, any poster work that you've been in part of, any previous attachments that you have done, so clinical attachments, write them down, what you've done, make them short and snappy, aim for about 3 to 4 lines for each experience of clinical attachment, I'd say. Make sure your reference is right at the bottom. They want a minimum of 2, you should aim for 3, just in case if one reference, doesn't email them quick enough or is out of the office or is on annual leave, you've got backup. And that's actually happened to me. When I was applying for the job that I have now, I gave 2 references, and one of them, he was on annual leave and he was like, I'm really sorry, like, can I do it in a week's time? And I was like, well, that's going to be a bit difficult. And then I ended up giving another email, and luckily for me, all 3 of them ended up emailing them back, which is perfect. But you don't know what can happen in life. Read your CV inside and out, because they will ask you about anything and you'll be very shocked. Like, I was shocked when they asked me about something. It was really random on my CV. I talked about doing a poster for ICMS, and they asked me about it, and that stunned me because I was a bit like, oh, you always have this perception of they don't really read your CV in detail, but they do. So make sure you know it in detail as well, because your CV only shows, it's like a blurb of you, right? But they want to know more about you. So you've attracted them, you've intrigued them with your CV. Now tell them more about yourself. That's what the interview is all about. And always show that you're well-rounded. So yes, talk about the medical experience in your CV, but talk about things that you've also participated in, like cricket or netball or football, or I do this charity work, or I used to work at an animal shelter. Just show that you've got other hobbies or other activities outside of this medical world, because they want to know that you've got something else going for you and you're not just head in a book constantly looking at cadavers and stuff. And then some top tips. So apply for multiple jobs. One is never enough. You want to have multiple offers, and then you can make your choice. Know your CV inside and out. Do some reading about the hospital, the location, what it has to offer. So I want to go to this hospital because it's got great location and it's surrounded by multiple things and activities that I'm interested in doing. You want to show them that you genuinely want to be there and you want to work at their hospital. Talk about goals that you've achieved for yourself. So, you could say something like, oh, my future is to go into sports medicine, so I want to gain as much experience as possible in hospital, and then hopefully apply that in my future for when I'm working on the football grounds, or something. Like, anything. You can twist any situation to apply to another situation if you know how, and if you show that, you're giving them an answer, and that answer tends to be the right answer. Hot topics, PEs, so make sure you do your reading on them, know how to identify PE, so shortness of breath, ECG changes, AtoE as always, MI, such as heart attacks, falls. They love asking questions about falls. 90-year-old Doris fell out of her bed. You've been asked to review, what are you going to do? Dementia, so dementia patients come in all the time, and obviously because of England's aging population, dementia is such a hot topic, know that. So if you know your hot topics of PEs, MIs, falls, dementia, and I'd say the other one is sepsis, you're completely fine. You will be covered for a good 80% of questions that you'll be asked in an interview. And in an interview, you don't get asked 3 that I presented to you today, you get asked 1, sometimes 2, depending on how short the question is, but 1 clinical question, 1 situation judgment question, 1 question about yourself, 1 question about why you chose the hospital, and then, anything you have to ask. And like I always say, it's okay to say you don't know, be completely calm. In my interview, my screen went blank and they asked me a clinical question, and they were asking me about the news score at this point, and I had no idea what news was. Like, I only knew that there was respiratory rate, heart rate, blood pressure, and all that on it, but I didn't fully understand how the scoring system worked back then. And as I was trying to answer that question, my screen went blank completely and I panicked because I was like, oh my God, like, have I lost this interview? And then my screen came back on, and I don't think they noticed, because after a couple of months when I did get my job, I spoke to the consultant and I was like, did anyone know? And he was like, no, we didn't notice at all. But the main thing is if you stay calm, you don't alert them of any difficulties you're having on your side, that you don't cause for any concern. But make sure you've got good internet connection, dress really well. This is you presenting yourself to them. Put your best foot forward, make as much effort as possible. And ask questions, because that's also your chance to ask them anything that you're having worries about, like, oh, I want to get into so and so training program, what do you have to offer to help me to do this? That's completely fine, you can ask that. But always remember your hot topics that are always going to come up, because if you're not answering the clinical question well enough, they're not going to be interested in your situational judgment. And then news. So this is what the news score is. So it's respiratory rate, your SATs. This SAT score here, this is for people who've got COPD. This is a scale 2. Everyone that doesn't have COPD will be up here. Are they on oxygen or not? Blood pressure, their heart rate, are they conscious, and their temperature. And make sure you know this thing, because in England they use this every patient will get a new score done when they get admitted every 4 hours. So when you're doing your AtoE assessment, remember and say, I checked the new score for this. And then based on the parameters, they will give you a score. So if they've got a really high new score, there's obviously something wrong with them. And they do ask you a lot about this, so make sure you know this really well. And lastly, does anyone have any questions?
So just before we get to the questions, I'm going to cut you off, Dr. Dhaliwal, sorry.
All right.
Okay, so basically just a couple of things. First of all, let me just share my screen, see if I can do that. Okie dokes. Rightio, just gonna get back here. Okay, so first of all, first and foremost, feedback. It is your gift to us and we love it. It helps us improve and it's great. So basically in the Q&A box at the bottom of your screen or at the top of your screen, if you click it, you should be able to see answered questions. Only one question is answered and the answer is the feedback form link. So you guys can click that and fill it in. It won't take you more than a minute. Also QR code here just for the people who want to make their life easier. And then just quickly before we do go into the Q&A, we're going to do the scholarship prize draw. Somebody keeps asking, how do you apply for the scholarship? So if you go on studymedicineeurope.com, basically they will have the article there on their webpage, the one I showed earlier. Let me see if I can bring it back up. Oh. So you'll see this, and basically if you click on that little hyperlink just over there, the yellow hyperlink, it will take you straight to the application. So that's that there. So while I actually get the winners for this, the rest of you guys, I guess, can fill out the feedback forms. So this shouldn't take too long. So basically we have all the names over here. You guys can check this website out. It's absolutely great. And it asks me to pick the number of winners. So 5. Okay, are we ready? Drum roll, drum roll. Way. It's honestly such a ridiculous feeling, the fact that you just clicked a button and these 5 people will have half of their tuition fees paid for, which is absolutely, it's just berserks. So the names are over here now. SME will contact you, but it's probably better for you to just contact them straight away on info@studymedicineeurope.com. So basically just drop them an email and tell them, you've won the scholarship prize draw to have half of your tuition fee paid. Congratulations, honestly. Angela, Abdulakar, Sabir, Nadi, and Mohammed, congratulations. All the best to you guys, and more success to you. So I'm just going to leave this up for the moment, and I'm just going to hit straight into the questions. So we do have a few really, really interesting ones. And I'm going to start with probably the toughest for Dr. Dhaliwal. So somebody asked, is it worth being honest with the interviewers, i.e. when you ask the question, when you're talking about, why did you study abroad question, is there any benefit to being honest with the interviewers, or can that just end up backfiring a lot of the time?
So that's a really good question. Okay, so reality is they all know that most of us go to study abroad because of grades and whatever. And you'll actually find when you start working, a lot of consultants send their kids to study abroad. I mean, a lot of consultants I work with, most of their kids study in Italy. So it's nothing to be ashamed about. In fact, you could say, oh, I did study abroad because of X, Y reason. All it shows is you've got dedication towards the job. But in reality, they already know the answer. So, you can always just be a bit, yes, you can say, oh, I studied abroad because I didn't get the grades. But would you really say that in an interview when you're trying to make a first good impression? It's not personally how I would set forward. I think you could probably dress it up a little bit more. But ultimately, they know. That is a hard question. But I would always say, talk about how it's cheaper, it's a better experience. Talk about the positives. Don't start your interview off with a negative. Talk about the positives you gained from studying abroad. You learn a lot of stuff in Latin. In England, they don't even do their anatomy in Latin. You could talk about cadaver cutting. You don't get to do that in England. A lot of universities don't offer that. There's a lot of ways you can spin it. But I personally wouldn't say, start off with a negative. Put your best foot forward and go in with a positive.
Mm-hmm. Absolutely, I couldn't agree more. Somebody asked, could you repeat the list of common conditions asked? I don't think there's any need for that. Basically, these videos go onto YouTube anyways, in about a week's time with some editing. So whoever asked that question, just check out the Study Medicine Europe's YouTube page, and in a couple of days, probably this will be up there and you can watch it all over again. Okay, next question. So what kind of questions are smart to ask at the end of the interview to the interviewers?
That's a good question. So you can ask things like, what do you guys have to offer in terms of training? So I'm guessing most of you guys will have a rough idea of what you want to go into. So in terms of if you want to study medicine, not study medicine, but as in progress your career in medicine, or if you want to go into surgery. So a really nice question you can ask is, if you're interested in medicine, an exam that you will have to sit is called the MRCP. So you can ask, do you have any support for, doctors wanting to take the MRCP exam? Or every Wednesday, every hospital does this thing called grand rounds, which is when they talk about a particular clinical case. You could ask about that. You could be like, oh, is there any way that junior doctors can get involved in grand round rooms? You can always talk about, are there any training opportunities? Are there any opportunities for teaching? Are there any opportunities for me to develop my clinical and my practical skills? These are really good questions to ask. You can even ask things like, if there's something particular that you want to gain experience in. So, you might be applying for a job in medicine, but you want experience in, I don't know, surgery. You could be like, are there many opportunities for, juniors working in other departments to be able to have a taster week? Things like that. They're really good questions to ask, and they do make it look like you know the system. And once you show that you know the system, you make yourself look more hireable.
Absolutely. And I think even simple things like, what kind of facilities you guys have for your junior doctors, or, what kind of support system you guys have, and just things like that, things that you would genuinely concern yourself with in the long run working there. Couldn't agree more. So the next question was, what is the best way to prepare for ethical scenarios? I'm guessing they're talking about the SJTs. I'll hand this over to you.
So I would say there are books out there that have loads of these different scenarios that come up, because these scenarios come up throughout your career. You can also get things on online, for example, just type in, common STJ questions or whatever, SJT questions. But ultimately, you just need to make sure you know the ethos and the ethos of the whole NHS, which is about patient safety being at the centre of all care, how to escalate and when to escalate. But to find examples, I would definitely say, you can just pop online, type it into Google, and it will come up.
Absolutely. I was actually going to say, because I remember being told quite a lot about Tomorrow's Doctors. I don't know if that's the latest version or is it like Good Medical Practice or something. It's basically a handbook made by the GMC for doctors to read, and it pretty much outlines a lot of the ethical stuff. But I think the other thing is that studying abroad and going back, and because we get fully registered as soon as we go back, there's certain exams we don't need to sit, like the SJT. Though these things I would say are good to practice. So if you guys go onto Google and just Google SJT questions, I think it's a very good sort of self-study thing to do, because it will help you understand how to actually approach those kind of situations. Because I think studying abroad, one of the things is that bureaucracy and sort of the hierarchical chain and all that stuff is handled very, very differently compared to the UK. I think what Dr. Dhaliwal said, you know, they're very sort of they're very strict in certain ways in regards to how you get things done over there when there is actually written procedure for it. So it's good to know what those things actually are. Even, and you know what, the thing is that I remember doing this, and a lot of the times, like not a lot of the times, but I think like sometimes I would just disagree. I would disagree with like what they're asking me to do. But honestly, that's to my benefit, because you know, being in that situation, if I didn't actually know the procedure guideline of knowing what to do there, I would do what I think is the best decision. But that won't save my job. Me following the guidelines and me following procedure is going to save my job. So no, I think that's definitely important to like try and practice those scenarios. Somebody asked, how many jobs would you recommend to apply to? I would guess all of them.
Yeah, I would say as many as possible. Don't, you know, obviously don't, you know, if you're not looking to move to Glasgow, don't unnecessarily apply for a job down there. To, you know, be sensible with your applications. But try to like I mean, it's lovely.
We have the biggest hospital in Europe, excuse you. I'm gonna put that out there.
You know, try and aim for like three to five. When you're aiming, I would say, like, as an international graduate, start off looking at places where you know they are in desperate need for doctors. I know that sounds mean, and you know, it's probably not the best thing you want to hear. You know, you probably have all these hopes and dreams that you want to go and work in a mainstream hospital. Reality is, to work in a mainstream hospital, you need some form of experience. So maybe like be more realistic, apply a bit more out there, and then you can always come and move back in, which is what I did. And that's completely fine, because you need to show you've got some experience within the NHS, and clinical attachments are great and all that, but you know, it's not really showing that you know how to do everything day to day. So as your first job, be a lot more sensible, and then you can be more creative as you move on and, you know, forward in your career.
Absolutely. Somebody asked, will we need to take the prescribing course? So they're probably talking about the prescribing safety assessment, PSA. No,
you don't.
Mavel, I think it is. I'm probably butchering your name. I don't know if you're a Bulgarian student, but I think as far as me and Dr. Dhaliwal can tell you, if you are graduating from Bulgaria, you do not need to do the PSA when you go back. You will get fully registered, and that will already be on the record. Although if you're from a different country, I don't think either of us can probably tell you anything for sure. And that's something you should probably ask somebody at the GMC. But if you are graduating from Bulgaria, no, you do not need to. Do all NHS hospitals have a similar interview structure?
Yes, they do. That's a really good question. So they all have this whole tell me about yourself, clinical question, situational judgment, and then about the hospital. The interviews that I've sat, they literally were all the same structure. And even when I participated in the Regis interviews on Thursday, it was the same thing. The only difference is for Regis, they don't ask them why they want to work at that hospital. But it's always, you know, tell me a bit about yourself, clinical question, they dive straight into it, situational judgment, an ethical question, and then what do you know, why do you want to work here? And then do you have any questions? And it's not, honestly, the interview doesn't even last that long. Depending on the question.
I think they're like 15, 20 minutes.
Exactly. Then they're over within a flash. You gain more confidence as you go on through the interview, and then you're a bit like, oh, is this over? I mean, I remember I sat one interview in between an on-call shift, and they just go by really quick. Like it's absolutely fine, but they are all of the same structure. Yeah.
Yeah, I absolutely agree. Right. So actually, this is a very interesting one. Somebody asked, do the references have to be from the UK or can they be from, Bulgarian consultants or a mixture?
So that's actually a really good question. So I personally, when I was applying, I went purely for English consultant only, just because it worked better in my favor. And the fact that it showed that I had experience in England and I had people who were in England to vouch for me. Having said that, I did have colleagues who did get references from England, I mean, from Bulgaria, like from, our PEDS professor or from their like biochem or whatever. You can do it. Ultimately, I would advise not to, just because you're applying for a job in England, not in Bulgaria. So you want to have references from England, right? Ultimately. Yeah, I know it can be difficult. There's nothing wrong with if you do want to go for someone in Bulgaria, but to make yourself more favorable, I would advise strongly to go for somebody from England and aim for 2.
Yeah, absolutely. I actually didn't know that, to be honest. I didn't know you could get any references from Bulgaria. I thought they had to be English or British consultants. So very, very interesting. I guess it's good to know it's a possibility, but maybe as a last resort.
Yeah, it's definitely a last resort. Mohsin's right there. I wouldn't advise it, but if there is literally nobody else you can ask, then go for it, because people do it. But to make yourself more hireable, always go for an English consultant.
And I think here's the thing, like the one thing I feel like people don't do a lot is actually get your teachers to start signing you off on things, even if they're like, competencies, as Dr. Dhaliwal was saying, or even if they are references. Like every time I have a new rotation or anything as such, and if teachers nice and willing, I'll always sneak a letter in front of them at the end, some sort of reference or something, and I'll just get them to like just sign it. They barely read the thing, and I feel like it's really good to have that piece of documentation over there, because chasing them up afterwards, if they remember you, can be a lot of hassle. So try and get things signed off while you can, and actually go through getting those templates for yourself to get it signed off. So how will we get a reference? Okay, so I think a couple of people asked questions in regards to, just gonna try and read this. Just wanted to clarify if the medical knowledge and learning will be so different in terms of A&E, etc. How will this affect coming to study back in the UK, our students who study in Europe? Okay, so I think they're asking, these are 2 questions really from 2 different people, but I think the basis of what they're asking is the medical education that different in regard to things like A&E, and also our students who studied in Europe at a disadvantage to those who graduated from a UK university?
I think I'm going to be a bit biased here, but I've seen, like, I teach medical students in England that come to the wards sometimes, and like you see how much knowledge they have, and I compare it to how much I had when I was at their stage. It's very different. They get thrown into the NHS system a lot quicker than we do. But ultimately, I mean, for example, they'll be coming into hospital in first year when they have no anatomical knowledge at all, and it's pointless. They'll be trying to learn anatomy in a ward, and I'm like, it's not viable. So there's not that much of a difference. Look at how many foreign international doctors there are. We have loads of doctors from India, Pakistan, Saudi Arabia, Africa. Medicine is the same everywhere. And, the sooner you learn that, I think the better it'll be for your own confidence. There's not that much of a difference. I think things that you will struggle at are abbreviations. I personally struggled with that a lot, was the abbreviations. I think my computer's gone a bit weird.
Oops.
Oh no, it's fine. So it's the abbreviations, I'd say, is the most biggest thing that you will struggle with. I did, for example, road traffic accident. I didn't understand that abbreviation for ages. I'd see it and I'd be like, what is this? You know, I don't know. I mean, certain words that you pronounce, they'll be slightly different.
I really got this. I've been calling it hydrocephalus.
Yeah, like, and you know, like, we say cephalosporins, they'll say cephalosporins. It's things
Yeah,
like
oh
that.
my God.
That
Honestly,
get to me so much because I'd be like, why are you guys saying it? So like the first time I said cephalosporin, everyone thought I was an idiot. They were like, what are you trying to say? And I was like, you know, it's an antibiotic. And I had to spell it out. And they were like, oh, you're trying to say cephalosporin. And I was like, how does that look like the same thing?
honestly, it's like my consultant was like, have you seen the patient with hydrocephalus? And I'm just like, I thought he wanted me to go see the patient because the patient has some rare disease called hydrocephalus, you know?
Yeah, true. It's just a thing, but but the actual real answer to why we pronounce things differently is because in Bulgaria they use a lot of American terminology because obviously your degree is American essentially. So that's why, and there's nothing wrong with that. There's not that much of a knowledge gap at all. Don't let anyone tell you there is. Medicine is the same everywhere, no matter where you go. It's just the way it's applied is slightly different.
That's to be honest, it's the approach, isn't
Yeah,
it?
and then I think the sooner you learn that, the better it is for your own confidence. Because I, like, especially when I first started working, I had this big thing in my head, like, oh my God, I graduated in Bulgaria, I probably won't be as good as all the medical graduates. Like, and that just automatically makes your confidence go down. And if you're not confident, it just makes you essentially bad, really. But you soon realize they don't know, you know, they're just like you. There's things that they don't know, there's things that they do know. They're just taught differently. Like their pathology is completely different to ours. We went and sat in slides. I'm sure everyone remembers sitting in the micro room, you know, that we're looking at those slides in the microscope with the microscope. They don't do that. That's not how their pathology is. But, you know, is it really different? It doesn't matter. We all know how to treat a heart attack. You know, it's not really that big of a deal. Don't get too hung up on that.
Yeah, I think the other thing is that, and from all my experience with all the doctors I've worked with, UK grads and IMGs, think of the advantages you have from living for 5-6 years abroad. And there are some serious advantages that come with that. One, you're a very, very sustainable person,
Yeah.
self-sustainable person. Like honestly, like you know, I was just talking to my brother the other day because he's just having his surgical interviews right now, and he's really trying to get a post close to home. And he's like, despite him being well into his 20s, he's afraid of the idea of moving out. Because he knows he doesn't really know how to handle that. Like that's obviously like, despite being a FY2 in the academic program, like that's not something he's been exposed to. So you're a highly adaptable and self-sustainable person. The other thing is that I think you have a greater appreciation for the job, and you actually, you can actually take that level of grilling from the job. A lot of the UK grads I've met, by the time they get into FY2 or FY3 really, they're ready to quit and drop out. As sad as that is to like hear and say, but like almost all of them, not almost all of them, but like a lot of them that I meet, shockingly, like absolutely, just don't are not enjoying what they do. If you went abroad to study medicine for 6 years, you do it because you love it, and there's no other justification for it. So a lot of them, you see them still walking around whistling and smiling, and they're just generally more resilient people because you've been through tougher circumstances to get where you are. And I think that always makes you appreciate that situation a little bit more. And then honestly, like this is the thing, like you might walk in there and you might not know the abbreviations and the mnemonics and the acronyms that they know, but that'll only take you a few months to catch up to. And once you do, they can't build up that resilience that you've built up in the last 5-6 years over those few months. And I think just keep that in mind, because I feel like that's a really, really important thing that we ignore.
Yeah, that's really true.
Yeah. So I'm just looking through these. I think a lot of people are asking, how do we get references if you're not in the UK? And if you're studying abroad.
I'd say get a clinical attachment, and while you're on your clinical attachment, ask really nicely to the consultant, towards the end of your clinical attachment. Don't ask at the beginning because they don't really know you. Ask at the end, do you mind if I use you as reference in the future? A really smart thing to do is, say if you've only managed to get one clinical attachment, if you become quite friendly with two consultants, you can ask them both, so you've killed two birds with one stone.
I mean, seldom is there like one consultant in the ward, so you will see more than one consultant.
Yeah, it's true. Yeah, just a clinical attachment, and then I'm sure someone's going to ask how to get a clinical attachment, and it's things like apply online, or there are loads of things out there that you can try and do to get a clinical attachment. Yeah, there's loads. You just need to know what to do and where to go, because it's not always so obvious.
Yeah, absolutely.
Shadowing a GP, that counts, guys. GPs do count as being classed as a consultant reference. A lot of people don't know that, but you can ask a GP, and I mean, don't ask your personal GP, but like go and shadow a GP and then get them to be your reference. That's completely allowed.
I was just ironically about to say that I've known quite a few people to ask their personal GP, and they've actually got some sort of attachment out of that. I guess to some more extent, it's just familiarity. I wouldn't even call it nepotism, but you don't have to work with that particular doctor. You don't have to work with your particular doctor. You can just try and use them as an avenue to set yourself up in that GP with another doctor.
Very true. It's very true. They're not going to go and check to see if, I don't know, so-and-so on the 23rd of March in 2019 went and did a clinical attachment at, I don't know, City and Bars Hospital. No one's going to check, but that's not the point. The point is you need to show that you gain something from the experience and you actually have someone to vouch for you.
Yeah. So we're gonna answer two more questions over here. So the first one is, if I couldn't get a clinical attachment, would it affect my chances to be offered a job?
I would say yes, because reality is the clinical attachments show you what working in the NHS is about. It shows you how they conduct a ward round. It shows you how, the system works, who has what interaction. It shows that you have made an active effort to want to be a part of this system. You've made an active effort to learn how the system works. Doctors that come over from like other countries that are outside of Europe, they actually have to do a clinical attachment for a minimum of a few months before they can actually, and then get signed off from that. And then they can start applying for jobs, people that sit the PLAB and stuff. So you should, in one way, take that principle and be like, actively try and get a clinical attachment. I get it's hard. And, sometimes you're not always in a position where you can get one, but ultimately to get a reference and to get to have something to talk about in your interview, you should aim to have at least one. I mean, I would say minimum should be about 2 or 3, but one by the very least if you're struggling.
And here's the other thing, a lot of people, they get their first clinical attachment after they graduate, because it's a lot easier to get it as a doctor.
Yes.
Than as a student. So what they do is they take a few months out just to do a clinical attachment before they go into work. And it's not a bad idea at all. And as applying as a doctor for a clinical attachment, you are more likely to get it, from my experience, from what I've seen anyways. So yeah, no, that's also an option. You can do it. Then you don't have to go straight into work. You don't have to go straight into finding a job. Preferably if you can get it done before you graduate, then you could probably go and start applying for jobs straight away.
It's true. Like, I mean, there are so many people that go on, graduate, do 6th year, get clinical attachment afterwards, and then they do it in that hospital for a month or so and then end up getting a job there. I mean, don't take that as an avenue, to go and get a job. I personally would say what Mohsen is saying is right. Preferably do it while you're at uni, because it shows that you're really active. And, then you can get a job, so you're not losing any time, because there's also a time period. You don't want to be out of work post-graduation for too long, because then, it's questionable. They want to know, what were you doing? You graduated in 2020. Why are you only getting a job in 2022? They'll ask loads of questions, but Mohsen's right. You can go after. You need to go and get one.
Yeah. And The last question we're going to answer today is, does your grasp on the English language give you an advantage to other applicants whose English is not as good? So I actually recently taught a course on the OET. So I know a bit about this in regards to this person's question.
I would say it does a little bit, very, very little, just
But
because.
if you've passed, if you've met the minimum for to get.
I mean, no one's going to look at your OET score. When you're graduate, the only person that looks at your OET and your IELTS is literally the GMC. No one cares. You know, when you go for your interview, no one's going to ask you.
They can't actually criticize your English.
They can't. You're right. They can't. They're not allowed to criticize your English. They cannot critique it because for you to get a GMC license, you have to show that you've already got that level of English. So you have that GMC number. The hospital have no right to critique you. No one has any right to say, you know, you can't speak English. It's a level playing field for everyone. You know, you've made it that far, you've got a number behind your name, you've got an interview, you've got a job, you're fine. No one can critique it. Of course, in terms of like knowing, you know, like local colloquialisms and things like that, that obviously helps. Like when we were in Bulgaria, like maybe if we all could speak a lot better Bulgarian, it probably would have helped us a lot more. But no, as long as you've passed your OETs and as long as you've passed your IELTS, no one has any right and no one can say to you about your English. It doesn't matter. Because ultimately, as long as you know your medicine, that's what makes you a good doctor. You know, not how much English you can speak. Because you would have proven that by getting your GMC registration.
Absolutely. And the amount of like IMG consultants I've came across who I wouldn't say speak bad English, but I would say like to a somewhat degree still broken. Shocking, honestly. I had a clinical attachment with probably, you know, one of the world's best authority on thyroid disorders. This guy was just a huge endocrinologist, and he was an IMG as well. He studied in Pakistan, and if you guys have ever met a Pakistani doctor who still has that bit of a timbre and tone in his voice and pronounces words a little different. So he would call calcium. And for all of you who are laughing, you're welcome. Like literally, I think so many people can relate to that. Like you'll hear Asian parents or Asian people calling it calcium. And it was just the weirdest thing. It was the weirdest thing for me because I'm just sitting there. I'm like, this guy's like literally the foremost authority on thyroid disorders, right? And he can't pronounce. It's not that he can't pronounce calcium correctly. He can't pronounce calcium, you know, the way the social norm is considered correct. So every time we were in the clinics and a patient would walk in, he would always ask them, you know, like what's your calcium levels, and the patient would always be like, excuse me, because the patient would be like, what's calcium, you know. And I remember I got really friendly with him afterwards, and I asked him about it, and I'm just like, you do realize you're saying it wrong? He's like, oh yeah, I know. And I'm like, why do you keep saying it? I've never changed for them. Like literally, and he just refused. He's like, that's how I say it. That's how I'm gonna continue saying it. And I'm just sitting there thinking, like, I'm like, should I just keep calling it hydrosyphilis?
It's true. I mean, I still go with my cephalosporin and I refuse to change.
No,
at the end of the day, then you've worked 6 years for your degree. You've worked really hard to become a doctor. You know how much English you know, you don't know. You've already proven that by getting your GMC license. No one can critique you about it. So don't let that faze you. Don't let that bother you at all. There are millions of doctors that work within the NHS that actually their native language is not even English. I mean, majority of the doctors that work within the NHS are not British born. So that should never bother you. And, don't let that be a factor that gets in your way. Oh, my English isn't as good. No, as long as you're a good doctor, you've got your license number. That's it. Only the GMC can question your English. No one else can. And remember that.
I mean, I think in all honesty, if you are struggling with English, that's something you should really try and focus to work on, not just for your interview and your job application, but you're going to be communicating with patients.
Yeah, it's true.
Colloquials and slang and all that stuff. I think that's definitely gonna come into use. But at the same time, being able to deliver that message across, not only is it important in regards to delivering medical information, but also in regards to building up a bit of rapport and trust between yourself and the, patient. So work on that, I would say. Like, like if that is something you struggle with, and that's something like, tons and tons and tons of resources out there on the internet for you to learn all languages but English, you get me? So yeah, I definitely think that's something, if you have space to work on that, and if you can, do it, and do it well, because the easier you can communicate with somebody in your working language, the easier your life becomes overall, I would say.
Yeah, it's true. I mean, nothing more frustrating when you can't speak to your patient and your patient can't understand you. You don't want to be in that position. But in terms of you yourself, don't let that bother you too much. Like, I honestly would say this, the main thing that gets to all of us international graduates, be it whether English is our first language or not, is confidence. Confidence is a big thing. You just need to keep being confident. Because, some people will be like, oh, I graduated from another country, I don't feel as confident. No, you've worked just as hard as anyone else. You've relocated, you've gone to another country, ignore all the stereotypes that are attached to it. You have a GMC license number just as much as the next person who graduated in England. You have every right to be here. You have every right to be a doctor just as much as they do. Ignore all the other things that come around it, because your biggest enemy will be yourself. You will create this whole perception of, I graduated in Bulgaria, people might think I'm less than, or I graduated in Romania or whatever, or, oh, my knowledge might not be as great as everyone else's. You just got to ignore it, Yeah, there's going to be haters everywhere, but you'll actually find the majority of them find it really interesting that you studied abroad, and, will ask you questions like, what was it like? Was it interesting? And you'll find that there are some things that you have more knowledge on than they do, like your anatomy, for example, will be a big one.
Absolutely. I think the other thing is, and I think this was the real sort of game changer for me, at least, is when I started meeting more UK grads and UK students and started talking to them, and I started asking them about their experience from uni to, becoming a junior doctor.
Yeah.
And surprisingly, the two things they say are the two things we say. I felt as if 5 years of uni didn't prepare me at all.
Yeah, it's so true.
Doctor, and they were all scared like hell. And I'm just sitting there and I'm just like, no. I'm just in disbelief, and I'm like, no, that's us, that's not you, that's us. And they're like, nope, it's us as well. It's all of us, that's the thing.
It's true. Like, the other day we had a cardiac arrest, and there were like F1s that had newly just graduated. So in your head, you're probably thinking, oh, they probably know what to do. And they all just froze, and they all just stood there, and you're just like, okay, they think exactly how you probably feel when you probably graduated. They're just as scared. I mean, they get scared to take blood. And they do that regularly, in England, some of them do. So honestly, I think it's this big stigma we all have attached to ourselves because we studied abroad. But in reality, there's literally no difference.
Absolutely. Okay. Sorry, just 1 second. My mouse is acting funny. Okay, guys. So thank you so much, Dr. Dhaliwal. It was amazing having you on. I think we got through some really solid stuff over there. And guys, I'd say take away from that as much as you can. Again, this video will be on YouTube later on the Study Medicine Europe YouTube page, so you guys can check out there again. This is probably something I'm going to watch again. So you guys definitely should as well. But thank you for being here. The feedback form is in the Q&A. You should be able to see it in the answered questions. So please do fill that in. It's a big help for us. And, you'll get your certificate for attendance and 50% discount code because of that as well. I think that's us for the month. And we will see you all next month. Any closing comments from Dr. Dhaliwal?
No, honestly, good luck, guys. And just be calm, be confident in all your interviews, but good luck to all of you.
Amazing. Thank you so much, guys. We will see you next month. Take care, stay safe, stay healthy, and goodbye.